I would say the biggest common question that is coming through is, I'll just read one and then I'll follow up with a few others. It's a longer question, but I think it encompasses a lot of the other questions. The question is, I'm scheduled for clinical trial infusion therapy at a major medical facility. This requires a 500-mile drive, overnight stay, and drive back home. Given the COVID-19 situation, is it wise to skip this treatment or trust that the facility has taken appropriate action to protect me? I've been self-isolating for the past 30 days out of fear of exposure. My specialist has not advised one way or the other. I don't want to be removed from the clinical trial for skipping a treatment. What would be your advice to that?
This is where I said the NIH has been very forthcoming in giving directives. If the patient is already on clinical trial, under mitigating circumstances, skipping a particular treatment would not affect the patient. It depends upon the clinical trial and it depends upon what is required. And that can be only told by the site which is conducting the clinical trial. And I just, I can't be very specific, but NIH has issued a guideline that study visits can be conducted by phone or video conferencing. Study visits could be delayed or missed, provided the study's intent is not, the principal aim is not violated. Laboratory testing could be done locally or delayed. And so treatment delays, etc., has been given provision. So the center which is conducting the clinical trial would be able to still keep the patient as a participant. If the question was if the patient was already on the clinical trial. Did I understand the question correctly?
Yes, yes.
I think you did, and I would just echo that. I don't consider the question to be so much of whether you are on a clinical trial or you're getting treatment off of a clinical trial. Clinical trial therapies come in different phases. The late phase 3 studies are typically using standard treatments, but just maybe in a slightly different way than has been done in the past or in a comparison fashion. And these are oftentimes very effective treatments that are necessary for the treatment of the patient. That being said, there are a lot of individual considerations. What is the incidence of the coronavirus at the location where you're traveling? Where can you be staying? Well, will you be isolated there? So in general, the American Society of Hematology has not recommended that you withhold treatments for active disease. And the clinical trials have made a lot of accommodations similar to what we're doing for patients not on clinical trials. And Dr. Dragunov mentioned that. So telemedicine visits sometimes are acceptable. Postponing treatments are oftentimes susceptible. And I would consider that if there's a really bad outbreak right at the time. But you need to talk to the local center and see if they're taking special precautions to triage patients, keeping sick people away, checking for fever. It's very similar in New Mexico where people are driving 500 miles sometimes to get a therapy and have to think about where they will be staying, etc. So in general, I would say don't withhold treatments if you have active disease, and there may be accommodations if it's particularly high risk in your case.
Okay. As I said, most of those, what about just routine, all of you sort of touched on it before, but what about routine things? So for example, should we maintain IV infusions? Is there a danger is there a danger to patients? When do you suggest we go back to the hospital to get our lab work done? And along those lines, we have many, many questions. So it's basically people are wondering about their regular, when they have to come into the office to get things done, how should they be thinking about that?
I will tell you what we're doing here. And I think, again, it may vary depending on your community and the incidence rates. We are having patients get all of their routine labs, but they will come straight, go to the laboratory, and then go home again. If they have a port, then they may come to the infusion area where they get their port drawn. If they are really not if they don't have active disease and we're just monitoring, then we'll do a lot of that remotely with telemedicine. And then the question of the risk of the intravenous, there's nothing risky about it, an IV infusion per se. This is not mediated by intravenous routes of infection. It's just the fact that you are in a clinic and there's people there and you don't know if the person treating you or someone else in the clinic might have the infection. So it's increasing your risk of exposure. But I think it's pretty universal that there are a lot of precautions being made to keep sick people away. For example, at our institution, everybody gets triaged at the door. They actually get triaged ahead of time by telephone calls to make sure they're not symptomatic. They come to the door, they get their temperatures checked, and then they get triaged into 3 separate categories. If they have symptoms, but they're not COVID-19 positive, they go to a special quarantine clinic. If they are otherwise fine, they'll go to the regular infusion clinic. And if they're immune compromised, meaning that they have low white blood cell counts, then we actually keep them in a special area as well. So a lot of precautions are being made. And I think that the cancer clinics may be one of the safest places for people to go to.
Yeah, I would echo that. This is important to understand. People can have guidelines, but literally they are only guidelines because individual center and where they are situated and where the COVID risks are different has to be taken into account. It doesn't matter whether it's the American Society of Hematology or International Myeloma Society or ASCO. They are only guidelines. That should be kept in mind. Number one. So having said that, in a pandemic area like in New York City, during the peak, we obviously converted as much as possible to oral medication, reduced the patient's visit to the cancer center, and patients who are on oral medication, and they have been already on the treatment for a while, we even forego their blood count test, which is done kind of monthly, kind of routinely, but actually the counts doesn't fluctuate. They have been on the Revlimid maintenance for 24 months. For the 25th month, whether they don't get the blood count, it is not important at all. So a lot of triaging could be done by physician depending upon their cases. Even in New York area, the centers have come up with innovative ways. I have one of my physician colleagues who's working in a center in his practice where the patients can come in, drive by, they have their bloods drawn, they don't even get out of the car, they have their bloods drawn and they go out. So people look at the ways to help patients go through this crisis with the maximum benefit. If the disease is progressing, you need treatment, you can get treatment very safely in any of the medical center, whether it's in New York City or in New Mexico or in Mayo Clinic. We have all been very cognizant of patient safety and the best outcomes. So I just want to reiterate that.
Let me ask a question from Cindy. So Cindy had a question that said, have any myeloma patients who tested positive for COVID-19 had previously received CAR T therapy? Will the CAR T cells help a patient recover from COVID-19 or make CRS worse? And I think patients will have a lot of questions in there about these types of immunotherapies. So Dr. Jagannath and Dr. Farah, do you want to address immunotherapies in general? This is a really key topic for patients.
Okay, I can address the CAR T cell treatment with an anecdote. So there is a young child with relapsed lymphoma whose disease was progressing and needed to get CAR T and got CAR T at Mount Sinai. And subsequently, the child did pick up the coronavirus, became COVID positive, but the outcome was absolutely fine. The child didn't even have CRS from the CAR T, nor had CRS or pneumonia from the COVID. So this should be kept in mind. But having said that, it is good to know that, but we are not doing clinical trials in New York City in any of the institutions. We kind of put it on hold because, as I explained in my talk, we were talking about a surge of 50 patient to 500 patient to 1,500 patient to 2,000 patient, basically overwhelming our institutional resource capacity and most of the beds becoming coronavirus. Under those circumstances, we were not in a position to conduct clinical trials, and obviously transplantation, CAR T cell therapy, enrolling patient on bispecific antibody, which already has a CRS, because you needed ancillary service support for these patients. Patient going through CAR T cell therapy could develop CRS and could get into the ICU, may need intubation. So you have to make sure. And they also need tocilizumab, which is also a drug often used for patients with CRS with COVID-19 at this time. So you want to make sure all the resources are appropriate for safe conduct of the clinical trial. So we decided to put on hold. So this would again depend upon the institution, the timing, everything at this time.
As everyone probably knows, Dr. Jagannath is a CAR T expert in myeloma, so I think a lot of people had that question, so I appreciate his answer. Most places that do CAR T therapy or transplants are not actively enrolling new patients and starting the treatment. There is oftentimes some chemotherapy given just prior to CAR T therapy, which depletes your lymphocyte count. So embarking on that therapy at this time might not be recommended. But if you've had it in the past, and maybe Dr. Jagannath can say if he agrees, I don't think that you would be at inordinate risk, because your recovery is usually quick, and the CAR T itself shouldn't have any impact on the COVID-19, except if they're overlapping symptoms.
You are absolutely right on that. We have had a number of patients who have gone through CAR T, and your center has actually sent one patient here to go through CAR T cell. And these patients have not gotten, COVID-19, either because the patient themselves were extraordinarily cautious and self-quarantined themselves. And those patients who traveled to a center and had their CAR T done, that's where the follow-up could be done locally. And that's where the protocol allows a lot of latitude, so they don't have to travel to the center where they got the CAR T done to get their follow-up visits done. That's where the NIH guideline was very, very helpful.
Dr. Gertza, we were talking about how CAR T, and my apologies because my portion was shorter than it should have been. The question was about CAR T and immunotherapies, and should you take precautions, and what's your perspective on patients with CAR T in the works or already having collected, or considerations, things like that?
Well, the situation, at least in our organization for CAR T, is the overwhelming majority of patients have relapsed disease that has failed all the other traditional therapies. That's not elective. It's not, oh, well, we'll do this when the epidemic subsides. They have an urgent need for therapy. And so this business about delaying is really, for most of them, not an option. In addition, these patients are in the hospital environment. These patients are hospitalized so they can be monitored for cytokine release syndrome. And we consider the hospital environment, because of the density of healthcare workers, phlebotomists coming by, nurses, dietitians, physical therapists, residents, fellows, to be a much higher risk situation. It's impossible to socially isolate when you're hospitalized for any reason, but patients with CAR T need a lot of monitoring. But I think here, this is a question of risks and benefits. And although the risk of corona is not insignificant, the risk of progressive myeloma and possibility of new bone lesions, progressive anemia, damage to the kidneys, I think that becomes a higher risk than the risk of contracting coronavirus in the hospital with universal precautions and hand hygiene. And so frankly, for CAR T, we're moving ahead with CAR T therapy, because for the bulk of our patients, CAR T is a treatment after patients have failed 5 different regimens. In our most of our trials, you had to have failed Velcade, Kyprolis, Darzalex, Pomalyst, and Revlimid before you can get the CAR T. And so we, quite frankly, haven't changed very much because we think in these situations, the risk of corona is dwarfed by the risk of progressive myeloma.
I thought I would maybe jump in and talk about bone marrow transplant since it's another
Okay.
cell therapy. And I saw a lot of questions about particular treatments. With bone marrow transplant, there is sort of a prolonged state of immune suppression that occurs afterwards. In the early phase after transplant, we give, generally myeloma is conditioned with melphalan chemotherapy. It induces cytopenias, meaning low blood cell count. In particular, the neutrophils are low for a couple of weeks, but then they recover. But despite that, there's a low lymphocyte count that often will take several more months to recover. That's why we don't give immunizations right away, because we want that cell-mediated or T-cell-mediated immunity to recover, typically for about 6 months. And so for that reason, I think we do have to take special precautions about considering whether or not a bone marrow transplant is indicated. We and most institutions are not doing that treatment right now until we see the peak of this epidemic pass away, because we are putting patients at increased risk potentially for a number of months after that therapy. Now, that being said, there's another aspect about bone marrow transplant. It tends to wipe out your immunity and you have to become revaccinated. Well, none of us have immunity to coronavirus unless you're one of these people who've gotten the disease and have recovered. And so unlike influenza, where people have been exposed before or they've been vaccinated, none of us have prior immunity. So once you recover your counts, even if you've had a bone marrow transplant, you should be in the same ballpark as everybody else, meaning if you're healthy and you have your immunity, your immune system intact, you should be able to get through the infection okay. So that's a little bit of a different ball game than some of these other treatments.
One of the questions, just to follow up on that about stem cell transplant was by Joyce, and she just said she's planning on having a stem cell transplant in July. So what do you do for future planned transplants when we don't really know what's happening?
It's a good question. And so we are looking at this every week. It's a dynamic picture, but we have decided as an institution that we are going to postpone transplant for myeloma until the wave of the infections has gone away and the case rate in the community is low, so that the chance of exposure will be low. In general, I consider the timing of a transplant for most myeloma patients to be elective, meaning if they wait 6 months, it is not necessarily putting them at particular risk if their disease can be well controlled. There are a few patients where they just are not responding well to other therapies, and they are responding to sort of chemotherapies, and transplant may make a stronger case in that case. But in general, the timing for an autologous transplant for myeloma is highly elective.
Great.
One other thing maybe I should say here about the future. My feeling is, as I indicated to you, that there is a tremendous collaboration between the government, the pharma industry, the FDA, the academia in the United States. So what this has done is, during this COVID pandemic, which has hit the Northeast and the West Coast much more severely, all these centers are extraordinarily active in testing many of these drugs. While we know the vaccine is going to be later, I have a feeling that the future is not going to be as dangerous as it was when the pandemic hit us in the United States, and we were a bit unprepared, I should say. But I think within the next 3 to 6 months, we would be, even if a patient goes through treatment, because patient has to go through treatment for cancer, will go through auto transplant or go through clinical trial, all of them will be activated. Some of those patients may develop the COVID, because the COVID is not going to disappear completely, but we will be in a better position to manage them. We can, first of all, find out very quickly, diagnostically. Then we can also find out who has previously been exposed, whether they have antibody, and whether there is recurrence. So in many ways, we are now, with eyes open, we can take care of patient much more safely in the future. So I want the cancer patient to believe that this country has put a lot of resources which we don't talk about in the news media, in really not only getting over this hump with social distancing, etc., but once we get over and get back, the medical community, the healthcare industry would be in a much better position to take care of these patients.
I just want to go back. There were two questions, and about as we talked about before, it's the fear of going out and going to offices and getting your things done. There were two related questions, and I'll ask them both, and I think they fit together. Has there been any discussion of home visits for blood draws? I'm surely due for blood work, which has already been delayed, and I don't go out in public at all. And it feels very risky this person feels it drastically increases his or her risk of exposure. And then we also got, what did I do? I scrolled down too far. Oh yeah, and here was another related one from another patient. He says, my IgG goes down below 400 about every 6 weeks. Whoops, somebody just moved me there. Okay. How important is it to get my regular infusion to decrease my risk of infection? And can he receive that via a home infusion nurse?
Okay.
And again, this is a policy that we use in Rochester, and that is that patients who have very low IgG levels are not routinely given intravenous immunoglobulin infusions. They have to demonstrate recurrent infections, the type that would normally be mediated by immunoglobulin G, that isn't responsive to narrow spectrum preventative antibiotics. So patients who, for example, have recurrent strep infections, we put them on long-term penicillin or doxycycline therapy. We don't give them immunoglobulin G. And just because someone has an IgG under 500, 400, or 300, that for us is not a trigger for routine immunoglobulin G infusions. There has to be recurrent infection. In patients that have recurrent infections that cannot be managed with a narrow spectrum antibiotic, we do use immunoglobulin G infusions, and there are both mobile phlebotomy units that will come and draw your blood, those services, and there are many, many home infusion centers that provide total parenteral nutrition, daily intravenous antibiotics, and can provide for intravenous immunoglobulin, and it's actually a Medicare covered benefit, so that remains an option. Most of the patients that I'm seeing for active treatment, they're basically getting their blood the morning of the treatment, and then 2 hours later are getting the treatment. And so we don't consider the exposure excessive. But in terms of the availability of both home infusion as well as mobile phlebotomy, it's there and available.
I would reiterate that probably depends on the community that the patient is living in. Certainly in some rural areas, it's very hard to get access to all kinds of services. I wouldn't necessarily consider going into a dedicated laboratory and having your blood draw to be at higher risk than having the phlebotomist come in a van and drawing your blood. So I'm not sure that there's a particular benefit there. Unless you have mobility problems or transportation problems, I think that might actually be the higher concern. We don't have an institutional policy for IVIG necessarily, but I do reiterate the Dr. Gertz's comments that it's not always necessary to give immunoglobulin infusions. Sometimes you'll see a cutoff of less than 400, but I usually will let the IgG level drift down further until the patient shows signs of recurrent infections. And those oftentimes are bacterial infections like sinusitis or bronchitis. There's a number of questions I saw in the Q&A feed asking about whether IVIG or immune globulins would help prevent COVID-19. In theory, that's possible, but that would only be after there's a significant number of recovered patients who are in the plasma donor pool that have antibodies that might be neutralizing antibodies that would prevent infection. So that's certainly not the case now. So I don't think that IVIG would necessarily provide any benefit against the coronavirus.
I think the policy of when to use IVIG was well articulated by Dr. Gertz, and I also agree with Professor Matthew Farrow on his assessment how things could differ. But in New York, we are still, it is going down, but we still have very high level of coronavirus. We are still in the midst of it. And our travels are restricted. So people, the nurses will be afraid to go into some patient's home to draw blood or give IV. So that is not a possibility. So that's why I said one shoe fits all doesn't work at all.
One of the issues that has been very much in the news is the idea of people who have developed COVID-19 antibodies and infusing them into other patients to fight COVID. Is that something myeloma patients should be thinking about?
Technology for using passive immunization with antibodies dates back over 100 years. Tetanus immune globulin was available for the treatment of active tetanus long before tetanus vaccination was available. So using immunoglobulin, or plasma is what I should say, for the treatment of active infection has pretty sound scientific underpinnings, but that doesn't make it proven. But there are many examples where you use hyperimmune globulin to treat active infections from previously infected patients. In fact, treating venomous bites is using antisera from individuals who've been bitten. And so it's the same principle of the passive transfer of antibodies from people who've produced those antibodies, but it still requires a trial because we don't understand the different types of antibodies to ensure. But in terms of the principle of should it be studied, is it rational to extract plasma from patients who are proven to carry immunity against the virus, makes just tons of sense. It's old, very old technology.
The FDA has provided IND, which is sort of a research permission for convalescent plasma to be given to patients or to be collected at blood banks and given to patients. And Dr. Jagannath actually mentioned that as well in his initial presentation. So there's different terminologies there. We talked about IVIG, which is from serum. It's immune globulins. It's been purified. Plasma is just whole proteins from the donor. And so there's a lot more to it in there. There's albumin and other things in there that's not just in the immune globulins. That being said, there is all the immune globulins. And so a convalescent plasma means that they've gotten it specifically from a coronavirus patient who's recovered, who's now negative for the virus, and they otherwise meet all of the blood bank donation criteria. It's the subject of clinical trials. It makes sense oftentimes for viral infections that those antibodies help prevent the initial infection more so than they help cure the infection after it's been established. But that needs to be studied to know if it's true. Some viruses are transmitted, or the virus will go from one cell to another in the body extracellularly. They'll get released. In the case of coronavirus, it's been shown that from the nasal swabs of people who've been tested, there is something like 50 billion viruses per human cell. So it does release an enormous amount of viruses, and an antibody in theory could neutralize all those as they're being released. There are other viruses that get transmitted from cell to cell through direct contact of the cells, and antibodies aren't necessarily so effective in those. HIV is one of those examples. So it really should be the subject of a clinical trial. It's an excellent idea. It's currently being done, and it may be helpful even in some sick patients, but it would have to be tested.
Okay. And since we're on this topic, I want to stick with this question. Will these COVID antibodies measuring IgG and IgM responses be reliable for IgG myeloma patients?
That's a very interesting question just now, because the convalescent plasma is obtained from healthy donors whose blood product is clean. We heard Dr. Matthew Farrow exactly tell you how it is done, and we do have that clinical trial. What we do not know is whether the myeloma patients, which we have quite a number of them, right now we are retesting them. We know some of them have the virus for a longer period of time, and now the serology is being done. I honestly do not know what the results would be, but this is actively looked at this time.
So I think, so just to clarify, I think what Dr. Dragunov and the questionnaire is getting at is not giving antibodies to a patient for therapeutic or preventive purposes, but rather measuring the antibodies in someone who's had an infection or to tell whether they've had a prior infection. So during the testing that most of people are getting right now is testing for the actual virus. It's usually a DNA or RNA-based test, and it tells you that there's viral particles present. But once it's gone away, the patient will develop their own antibodies, and that can be measured from the blood as an indicator that they've been exposed in the past. Depending on the level of antibodies, it may also be an indicator of whether they are still immune to future infections. But how much is necessary to prevent future infections will need to be determined by, studies and statistics. So we don't know the answer to that. But there's a lot of talk in the news media and elsewhere about these antibody testings to come along and be available. I even heard about an at-home test that a German company is trying to develop so that people don't even have to go out of their house and figure out whether they're potentially immune to COVID-19.
As long as Amazon offers overnight delivery.
Oh,
There you go.
don't touch that one. We have a number of questions on daratumumab or Darzalex, which is the commercial name. And I'm going to ask Jenny to back me up if I miss any of these questions, because there are a few of them. I don't think they'll take long. But, and we'll start with the simplest one. Is there an oral substitute for daratumumab?
No.
That was easy.
That was easy. All right, but
That's an easy question, but there is, I believe, a subcutaneous formulation that's coming along. We're currently using that in clinical trials for patients after myeloma, for transplant for myeloma. That's a subcutaneous injection. The advantage is that it's much quicker, so the patient's not sitting there for hours and hours in the clinic getting their treatment.
Okay. Does daratumumab treatment make one vulnerable to COVID-19?
We cannot answer that at this moment, whether it makes them any more vulnerable. You know, like Dr. Gertz said, if you're, following all the precautions, distancing, going to the center and taking all that, and if you're not exposed to the virus, you're not going to get it. That's number one. So it doesn't preclude you from getting an important treatment if your disease is progressing and you need treatment, just like he articulated for CAR T cell. So I think if you need treatment for your disease, you should get it. But earlier on, Dr. Gertz also said that you can reduce the frequency depending upon where you are, whether you skip one, if you're on every other week, whether it could be once every 3 weeks, because there was a study with the melflufen in Europe where they gave it once every 3 weeks rather than every other week. So you can space it out, So those are all options available depending upon where the patient's disease status is. Patient who's on daratumumab, pomalidomide dex is in remission. They could be on POM dex for a couple of months till that big surge goes away, and then you can resume back. So that's why it is not a straightforward one answer, but maybe Dr. Gertz can explain a little better than me.
Well, and a follow-up question, I guess, on that. So one of the questions was, how long can I go? Because in talking to some other doctors, they said, well, daratumumab really lasts a long time in your system. So you can extend some of those things or space it out a little bit more, but like how long is too long to go?
That is a different question. The ability to detect daratumumab, something in the blood level, could go for a long time, up to 6 months. But to have the treatment efficacy level, that is not the same thing. So being longer is one thing. And just because you skip 2 months, like in New York right now during the pandemic, where all the hospitals are overwhelmed, you don't want to be there, by skipping 2 months, then when you restart it back, you can get it every other week and build up your blood level and then keep going monthly. So you have all the opportunity. More important is how critical it is to administer daratumumab for your disease management at this time. If you just started for a relapsed myeloma, rapidly progressing just last month, even at Mount Sinai, we are still giving those patients daratumumab. So it is a matter of timing. That's why I said, Dr. Gert's articulation of this was very good earlier.
It does depend on where you are in your disease process. I think it's naive to think that the myeloma population is static in plateau, but that in plateau phase, the number of new myeloma cells that are produced is balanced by the number of myeloma cells that die off, so you're in a stable plateau. You stop giving the daratumumab and a new myeloma cell forms, then what? So the antibody hangs around on the myeloma cell surface for a long period of time, not in the plasma, it's on the cell surface. So you get a new myeloma cell, there's no daratumumab around the body. So a lot of it depends then on how high risk are the genetics, what's the proliferative index to determine, is it okay to just delay the dose a month or 2 months? I think that, again, this is what's the risk of corona? What's the risk of progressive myeloma? And for most of these, only the provider can answer that question about the situation. Someone who's been on daratumumab maintenance for 3 years can probably skip 3 doses, 5 doses, who knows? But again, those are only answerable questions, and they have to be individualized for every patient. Dr. Jagannath said one size doesn't fit all. It's true. You have to individualize these decisions, and we can't sit in front of a video screen and give an answer that's appropriate for a broad patient population.
Yeah, I think that that's one of the, Dr. Hillengoss had mentioned to me that, the thing that he has learned about this is that each individual COVID case is as heterogeneous as each individual myeloma case.
Mhm.
And I think that's important for everybody to understand. And just to follow up on this discussion, you've answered this question, but I just want to put some emphasis on this for the particular person who asked the question. How long can one delay monthly daratumumab without impacting the efficiency of maintenance treatment post stem cell transplant?
Well, Dr. Gertz, that's probably what you just said, right? It depends.
Right.
Right, I can't answer the question.
Yeah.
And there's no, I'm sure that there's no, quote, safe answer. You need, once you've achieved plateau, it requires monthly to maintain saturation of the epitope, the protein on the surface of the myeloma cell that the Darzalex is attaching to. And so again, it's all in terms of, if I had someone who was 42 years old with aggressive myeloma, I wouldn't be worried that much about coronavirus. But if you give me someone who's 84 years old and they have chronic obstructive pulmonary disease, lifetime of tobacco use, those are comorbidities that could make corona really much higher risk of being fatal. And in those situations, saying, gee, now maybe the risk of coming and getting your blood drawn and going and sitting in a chemo unit, even in a private room, may not be justified. We're just going to sit tight. But again, each person's going to individualize that appropriately.
Okay.
I would just like to reiterate there as well. So daratumumab after transplant is currently the subject of clinical trials. So there's a lot of information we don't know yet. One is the overall benefit in that setting as opposed to Revlimid alone as maintenance. And the other, really, the question here is not just, is the treatment effective, but what is the timing? And oftentimes we have even less information about the importance of the timing of a treatment, if that matters at all. So for example, if you postpone a treatment now, can you get just as much benefit by doing that treatment later on? And so I think we should acknowledge that we don't know everything. And so, so we have to kind of use our best judgment. And also the fact that every patient is so much different in terms of what they've been treated with, how their disease responds, what the manifestations are. So there's a lot of factors to consider there. And so yeah, we definitely need to encourage the patients to talk to their providers and see what makes sense for them.
Mm-hmm.
And one last thing I wanted to say, when we are talking about postponing treatment, daratumumab or Kyprolis or any of the IV, you are basically talking about at the most a month or maximum of 2. Even in New York, we are all ready to, rock and roll with this treatment of patients in May. So yes, we saw the surge starting in March and we plateaued and now going down in April. and in May, the patients will all be back on the treatment. So you also have to contextualize, what are you talking about, skipping a dose here and there, as opposed to putting it on hold. This is not for months to come. It is just for the short window. That's what is important to keep in mind, and work with your doctors.
Good
Like
point.
like everything else that we're all currently going through, patience is the key word, I think, on this. I have one more DARA question. If I missed one, Jenny, please ask it after this. One question is, can daratumumab lead to respiratory weakness? Since we know that that's the major effect of COVID-19. What's your thought on that?
Do we know about the long-term lung effects of people who've recovered from COVID-19? My assumption is that the people who get severe disease on a ventilator with adult respiratory distress syndrome, or ARDS, they may have some prolonged respiratory function impairment that may take weeks or months to improve.
Okay, but in the sense of daratumumab causing respiratory problems,
I'm sorry, I didn't understand the question, I guess.
Yeah. The question is slightly, if I rephrase it, is daratumumab makes you much more susceptible for respiratory infection and therefore for coronavirus? It is true that there is slightly higher incidence of upper respiratory tract infection reported on patients with the daratumumab, but this has not ended up causing, because we have taken care of patients in New York, those were on quite a number of patients on daratumumab, etc. Among the patients who have been admitted, it is not predominantly patients who had dara. As a matter of fact, we had a smoldering myeloma patients, we have had early myeloma patient, then we have relapsed refractory myeloma patient, and as Dr. Mori alluded to, more than that is your age, your comorbidities, those things play an important role. Otherwise, as I said before, the incidence of coronavirus among the myeloma population or their ability to get over all seems to be fairly good. That's an important message for the myeloma community to bear. So you don't have to be sitting there worried that you're a sitting duck and it's going to get you.
So I would just reiterate that there's very little information that's been published in the literature because we're so early in this, in learning about this disease. So Dr. Jagannath's experience, I think, is very valuable. But ultimately, we need to look at things in a systematic way to know what the risk is. And there are a lot of questions in the feed about, does this particular treatment cause risk or another? And I think right now, mostly what we know is the known side effect profile of medications may put you at some increased risk. So for example, both neutropenia and low, which is low neutrophils in the blood, and lymphopenia, which is low lymphocytes in the blood, are both known to be risk factors for more severe disease if you catch the virus. Probably everyone's going to catch the virus at the same rate, but you may have a harder time getting over the infection. Some myeloma treatments do that to a greater extent, some do not. We talked about a bone marrow transplant, which is probably the most severe. Most of the other myeloma therapies don't cause severe cytopenias, but that may be something to discuss with your provider, because if your disease is in remission, you're just on maintenance, and you do have a very profound lymphopenia or cytopenia, you may want to hold off on your treatment just because of the infection risk. On the other hand, if you have active disease, again, that risk-benefit ratio may be much different in your case.
And I have another really simple question, and then I'll hand over to Jenny. Is there an oral substitute for implicity?
No.
Okay, I knew that would be short.
Okay.
And Jenny had a question. Jenny?
Well, there was a question in here about IL-6, and I think that's an important one to ask. So IL-6 is an inflammatory marker, but most myeloma patients don't usually get tested for IL-6 levels because the inflammation can be caused by other sources and things like that. But yet there's tocilizumab, which might, the cytokine storm that you're hearing about is reduced by tocilizumab. And then Dr. Jagannath, you mentioned about something about being asymptomatic. So Are IL-6 levels higher in MGUS, smoldering active myeloma patients in general? Should that value be looked at? And what's your opinion on that?
Well, I can tell you the CRP is a very good surrogate marker for IL-6. And CRP and beta-2 microglobulin quite often get done in patients. And CRP gets done by the cardiologist too, because they like to follow the CRP markers, and they, give aspirin and statin and things like that. So I think that, you can feel almost most myeloma patients, one way or the other, would have had an idea about what the CRP is. Now, coming back to IL-6 in a cytokine storm, such as CAR T cell or in COVID situation, that is an explosive amount of IL-6 being produced that could be actually measured in the serum. Whereas a regular myeloma patient in MGUS or smoldering myeloma, active myeloma, I don't think the IL-6 level in the blood would be of any benefit. There is a different disease like Castleman's disease or something like that. Then you can measure that and it could be of benefit for you, but not in a regular garden variety MGUS, smoldering myeloma, or multiple myeloma. And I think in Mayo, they also looked at IL-1, anakinra usage, etc. Maury, you wanted to say anything on that?
We don't measure any of those cytokines routinely. That is not part of an evaluation. We don't obtain a baseline. In patients on trials with anakinra, those things are measured, but that's just part of an investigational type of, experimental sidebar to the clinical trial. It's not something we measure. I couldn't even tell you off the top of my head what the frequency of IL-1 or IL-6 elevation is in MGUS, smoldering, or myeloma.
Okay, good to know. I also have a question. There have been several questions too about light chain specific myeloma. Are people with light chain only myeloma more susceptible, or what's your opinion? Have you seen any patterns?
Oh, I don't think that it is, because even with patients with heavy chain myeloma, they don't have functional heavy chain immunoglobulins. Just because your IgG is 1600 doesn't mean that you have any protection at all. You have a monoclonal protein of 1.4 grams per deciliter, then that 1600 is all myeloma protein. There's no protective ability at all. And so you have suppressed immunoglobulins, all three heavy chains suppressed with light chain myeloma. With heavy chain myeloma, you usually have two of the heavy chains suppressed, but the one that isn't suppressed isn't normal. And so I don't think one can distinguish and say that there's a differential higher infection risk in light chain myeloma.
And I have one more question
okay.
to compile from the questions, if you don't mind.
Sure.
So one myeloma investigator had a hypothesis that potentially Revlimid at a low dose, because it activates NK cells or natural killer cells, might be offer some protective benefit. But at the immunosuppressive level at a higher dose, potentially, maybe not so much. Do you have any thoughts on lenalidomide in general?
Well, lenalidomide is an immunostimulatory molecule, and it is dose dependent. Actually, higher dose makes it even more immunostimulatory. And now we have pomalidomide, which is supposed to be stronger than that. And then there is yet another drug called CC220 in clinical trial, which is supposed to be even more immunostimulatory. So that's what we can say. So I don't think somebody who's on treatment with 25 milligrams should have to worry that it is suppressing their immune system or whatever. It is an immunomodulatory molecule, dose dependent. So I don't think that should be a concern.
And we have a question here from a good friend of ours who's an academic scientist, so be careful. And he asks more of a philosophical, well, practical and philosophical question. Which myeloma drugs may help against COVID-19, and what are the possible mechanisms of action?
Okay, well, first of all, you have to say there is a drug in clinical trial. So when I say clinical trial means we don't have the proof yet, and it is a randomized clinical trial. And that's the one which I told you is selinexor, which is in clinical trial. And they have preclinical data to support it has antiviral activity. And the study is approved in the United States by FDA and also in multiple European countries. So many agencies have looked at it and have looked at the preliminary data, etc. So I would say that at least it is in the clinical trial. And how it may work is because it is an expovio, it prevents the exportin 1, that is to move the RNA, because the DNA has all the message and it has to move to the cytoplasm to make it into a protein. So that a lot of messenger RNA and proteins move in and out of the nucleus. And this one blocks the exit of many of these proteins going out of the nucleus. And some is required actually for viral replication, even though it is an RNA virus and it grows in the cytoplasm, but is capsid and some of the protein production, it has to corrupt the, the cell's protein making machinery, and some communication with the nucleus and transport of the RNAs to the cytoplasm is required, and therefore it has shown antiviral activity. So that's to explain to that. Anecdotally, people have said, or some study, that even Velcade could have an antiviral effectiveness, but that's not in clinical trial for that purpose. So I wouldn't think that it has, gone up to the level where people thought they could go to an FDA and create a clinical trial. But there are other non-myeloma but cancer drugs called BTK inhibitor or Bruton tyrosine kinase inhibitor. And that is because when the virus is in the cell, there are ways the receptors are activated due to the presence of the virus. It's an innate immunity. They are called toll-like receptors, as if the cars have to pass through the toll booth. These toll-like receptors monitor the viruses getting into the body, and they immediately activate the cell. And that activation pathway is probably also in the pathway of BTK inhibitor. So when there is a cytokine storm, it can dampen the cytokine storm so that the patient doesn't have an explosive immune reaction that causes them mortality. So those drugs are also in clinical trial. So when it is in clinical trial, and actually an early publication letter in the Blood has been reported by Steve Trion. So I think these kind of drugs are there, but they are all on clinical trial, and that's what I wanted to emphasize.
Okay. One of the things in an event like this, there's a wide range of audience members. We tend to assume they're all brilliant, grizzled myeloma patient veterans, but we also have brilliant, newly diagnosed people who are still making sense of some basic issues. So if we could just take a not too long, but just a couple of minutes, and if you could take just a couple of minutes to explain the difference between active myeloma and being in remission.
I'll start off there perhaps. And myeloma comes in a lot of different flavors and varieties. So there is a risk, especially in this forum, where we make statements with one thing in mind, but it may not pertain to somebody in a very different situation. So myeloma sometimes presents as a very slow, indolent process. You might actually detect this abnormal protein in the blood, the monoclonal protein, for years and years ahead of time, even though the disease burden is very low. Other patients present and may have a much more rapidly explosive disease. So that does vary a lot from patient to patient. And we can't always tell the difference, but sometimes there's some genetic factors in the bone marrow biopsy that we might see that may help separate those out and prognosticate. Furthermore, patients who have more advanced disease, sometimes it presents as a very diffuse disease in the bone marrow that wherever you do a bone marrow biopsy, you'll see it. They may have low blood counts because the bone marrow fills up with so much disease, and eventually they become anemic or thrombocytopenic. Other patients have a much more patchy disease that forms these plasmacytomas that eats away at the bone. And if you do a bone marrow biopsy in a different location, you may not see it at all. It only shows up on x-rays, and ultimately they may suffer from fractures from the bone being structurally weakened. And finally, the myeloma protein itself. Myeloma is a tumor of plasma cells. It makes these abnormal immune globulins they may deposit in tissues, and particularly in the kidneys, and cause kidney failure. So the presentation is quite different. They're all plasma cell dyscrasias. In the advanced form, they're all called myeloma, but it really is a lot different in individual patients. So we have to learn about how the disease is in your case, how rapidly progressive it is, in deciding what the best therapy is. What was the
And what's remission?
is that the crux of the question?
I think that's the crux of it. Yeah, we just want to make sure
I'd
that
like to-
everybody,
I'll just add a little
it's a
bit,
complicated
and that is
disease.
when myeloma specialists talk to each other about response and remission and the status of the disease, in the majority of instances, what we're really talking about is what is the myeloma protein doing? Whether that's the heavy chain or the light chain, what is the myeloma protein doing? And there's only three things it can do. It can go up, it can go down, or stay relatively stable. And when we talk about remission or response, we're really talking about the fact that the patient's myeloma protein over time is essentially stable and unchanging. If you graph the level of the protein over a period of months, it's a horizontal line fundamentally. And that would be considered a response. If that horizontal line is kind of almost not measurable, then typically that response would be complete. If that line was 90% below the original start, then we'd say that would be a very good partial remission or partial response. And if it's greater than 50%, a partial response. So it's all about what is my protein doing over time. So every myeloma patient needs to know which protein is relevant. Am I looking at my IgG or my IgA or my M spike or my light chain or what? You need to know what that parameter is. And you actually should be aware of, is it changing? If it is not changing, most individuals will say that means you're in response. If it's rising over time, that usually means you're progressing or relapsing. And if you're early into a new therapy, a decline would indicate a response. So we're really just talking about protein levels over time. And in my own mind, when I think about it, the longer the protein has been stable or in response, also referred to as in plateau, the safer it probably is to start manipulating the treatment to reduce the frequency of exposure so you don't have to be virally exposed.
Okay.
Okay, great.
We've,
Do you mind if I pop in
well-
here and ask a question?
sure.
I just have to say
Sure.
this is so amazing. It's just so amazing. It's fantastic. So thank you so much for all these answers to these rapid fire questions. Claude has a question about not just necessarily smoldering of myeloma, but this applies to all myeloma patients with kidney issues. Do kidney patients, are they more at risk for COVID-19, having severe symptoms or responses to COVID-19? And he said that he gets an injection of Aranesp. Yeah, okay, so I wasn't familiar with that drug. Anyway, just
Erythropoietin.
yeah, okay. Broadly for kidney issues, what's your opinion for myeloma, smoldering myeloma?
Well, if you have kidney disease that's associated with myeloma, by definition, it's not smoldering. If you have kidney disease that is diabetic, hypertensive, polycystic, that is not associated with myeloma, it doesn't mean that you're more likely to get COVID, but you now have a comorbid condition. We talk about chronic heart, chronic lung, and chronic kidney disease increasing the risk of having very serious complications. So patients who are having chronic kidney disease that is unrelated to the myeloma need to be really even more vigilant, because the consequences of contracting the infection can be quite serious. And Aranesp, trade name, generic name is darbepoetin, is merely a medicine to try and improve the blood hemoglobin level, because that hormone is normally produced by the kidney, and if the kidney is impaired, it produces less hormone that results in anemia that can be corrected with the use of the air nest, but that would have no impact on response to infection, risk of infection, the like.
We've also received a lot of questions related to vaccines, and I'll start with the easiest one first. Would a potential vaccine likely be a live vaccine and therefore risky for myeloma patients?
Oh, they are all in trial right now. I don't even know what kind of vaccines are in trial. So whether it is live or dead or piece of antibody or whatever it is. So I can't.
They're looking exactly like influenza vaccine, inoculated in the chick embryos and then harvested from the yolk sac. And so almost all of the things are looking at dead virus, just for antigen exposure. The bigger question is, so you've got it, will a myeloma patient respond to it?
The other is, this is a patient who's in post-stem cell transplant. What is the current thought about vaccine administration? Mine are being postponed. Are any indicated sooner than others, specifically pneumonia?
There is not particularly a reason to suspend your vaccines greater than the generally recommended time, except if they are trying to expose your coming into clinic and have potential exposures in that setting. So that'll have to depend on the resources and availability at your transplant center and what whether they're able to do that safely. Most of the vaccines are preventive. The timing is not so important, so a short-term delay is not a big problem. Of the things that are the most valuable, I would think that the routine influenza virus and the pneumococcal vaccines would be the most important, because you wouldn't want to have multiple respiratory infections all at the same time.
A more practical question that has come up a couple of times. How should myeloma patients think about planning for vacation in late June or this summer?
That's a nice question. I think it will all depend upon where they are going, what the travel restrictions are to the place they are going. So maybe June will be a bit too early because people will be getting back to work and things like that in May, I suppose. And it's kind of difficult to answer, and depends upon where they are going.
I think we all want to know the answer to that question, not just myeloma patients.
One practical answer to consider is I can think of 5 different myeloma meetings that have been postponed because of this virus. Meetings for myeloma scientists and clinicians, and ask, well, when are they coming back online? But I don't know of anything that's coming before September. I'm just saying what's going on with the people who make decisions about healthcare providers that go to myeloma meetings. It's September and October. I don't know of anything that's coming in August.
So I think it depends where you're vacationing. So I went off to a national park and they were closed, but the wilderness was open. So if you want to go hike in the wilderness, it's not a problem.
So Sandy Wise, this is Paul Alstrom, Jenny's husband. Sandy Wise has a question. What phase of opening America are myeloma patients able to resume to more normal activities? What activities are considered more at risk? And this is a question that we're grappling with here in the state of Utah as they are trying to figure out their go back to work strategy. And there's been a lot said about the herd, like you have herd A and herd B. Herd A could be the at-risk herd, and herd B, the people that would probably be asymptomatic in getting the disease, like all the sailors that were on the ship. 375 sailors got coronavirus that were asymptomatic on that ship. And so one of the things that they're considering is putting the people that are at risk, having them, this is a battle, and having them shelter in place for longer while letting the other people go back to work. And then as a complex idea, but if you could pull it off, you could go back to work faster if you could separate those two. Separate the at-risk group.
Well, I don't think we know the answer to this question, so I'll just editorialize. it's not necessarily putting the patient who's susceptible at risk to putting that person with somebody who's recovered. In fact, the person who's recovered is not going to transmit the disease because they're immune, assuming that they're now recovered to the point where they're not shedding virus. And so when you're on kind of the down phase of an epidemic, that's because you've either taken extra precautions or because a lot of people have become immune. And so I think that's the thing that we have to learn what to do. It's probably going to depend on every industry and how much interaction there is between people. But how can you prevent transmission between susceptible people or between an infected person and a susceptible person in an industry? Or how can we increase the number of immune individuals? So we know a lot in healthcare about preventing the spread of viral infections. And I think that outside of the healthcare industry, they have to start thinking about those things too. And so some common things would be, don't go to work if you're sick. Allow people to take time off and have sick leave if they have fever. Maybe they should be screened at the door for fever or symptoms. How can they be separated at work? And then what kind of interactions do they need with the general public? So it's not absolutely necessary to get over an epidemic to have no transmission of the virus at all. What you really need is that there to be less than one transmission per patient. And if that's less than one, then it's going to gradually go away. So we don't have to be perfect. We just have to really minimize it. And we can use the same lessons we know about in the healthcare industry out in the general public. And I think we can get over this. We really do need that exit strategy to figure out how you get beyond just staying at home. That's obviously not a long-term solution.
Mm-hmm.
I think this epidemic has fundamentally changed in our society what at work is going to mean. I think there are a lot of people who are finding out that their desk job can be done at the desk at home and that the meetings can be done quite effectively via Zoom. And then the employer is going to figure out, well, then I don't have to provide them with a floor and lighting and custodial and a parking space, and it's an awful lot cheaper to have them come in maybe half as often, and maybe I'll have one desk shared between 2 employees. I think at Mayo, we're already, as we begin to reopen, are going to start segregating our phone and video appointments to one half day and the face-to-face appointments to the other half day, and have providers stagger so that at any one time we're going to have half as many physicians on site, because we're getting pretty comfortable with phone call and video and other non-face-to-face ways of doing consultation. And I think it's going to really change what the workplace looks like going forward.
I totally agree. I have a couple questions also that I've seen from Mariella and Vicky and Adrian and Charles that are all kind of related to the same things. When you think about going into the clinic for labs, for a doctor's appointment, for extended travel in Charles' situation, for a bone marrow biopsy, how long do you delay those things? Do you delay them right now? Do you go in? I was supposed to go get my labs checked and felt really uncomfortable going in, but then I ended up going in 7 in the morning. I was the only patient on the floor. I mean, so everything was sterilized, very few people there. So it was fine. But
so that's the irony. There's actually a lot less people in the clinic, and there's a lot more precautions being taken. Our overall case rate is very low, so I feel like people are not really at an extraordinary risk. In fact, they're probably generally at less risk than for general infections as they have been in the past. You know, we are trying to minimize people coming into clinic. We have telemedicine visits. That's why there's fewer people there. But some of those labs and tests really are important. So you should talk to your provider about it. You know, maybe you can go a month without doing it, but that's so important for how we monitor this disease. We have this luxury of being able to follow it with just a simple blood test. You're not going to get the virus from a needle stick. It may be a matter of who you encounter on the way there. So take some simple precautions. Wear a mask if you have one. Wash your hands after you leave any public area, and I think most people will be fine.
Again, it has to be individualized. So if you're getting a bone marrow because your doctor likes to do one for surveillance once a year, that's completely elective and just forget it. If you need a bone marrow to qualify for a clinical trial for relapsed disease, then you're not starting treatment until you get that bone marrow. Our employees require that their temperature be taken twice daily. They're all wearing non-cloth masks. They're gloved. And so there's a lot of precautions to ensure that infection isn't contracted. A patient who's I've been checking the blood count once a month to renew their Revlimid, and the white count's never abnormal, and they've been on it for 3 years, and now they're due for Revlimid. I go, oh, just forget it. Just skip the blood count. I'll send out the medication. So again, it all depends on where you are with the disease. But someone who last month had a white count of 800 on the Revlimid, I don't know if I want to go ahead and push the next month without knowing the count. So every individual is completely different in terms of how urgent is it for this testing to be done.
Next slide. There were a couple of questions that came in that felt they heard a contradiction between Dr. Jagannath's presentation and Dr. Gertz's presentation.
Oh, I'm right.
And we're going to put Dr. Farrow in the middle as the referee on this. So I'll go through both of these. So, Dr. Jagannath seemed to be less concerned about myeloma patients being at increased risk, while Dr. Gertz stated that as myeloma messes with our immune system, we are at increased risk regardless of treatment. Can you clarify this, and is there a contradiction in this?
Well, what is mentioned? No, that's a good question. That's a very good question. Yes, myeloma patients have immunocompromised, but to our surprise, from our experience in the COVID surge in New York, we didn't find that myeloma patients, even if they are at home, they because the spouses or somebody got it in, they were not infected. I gave you the case of a woman whose husband came in with COVID, and she didn't develop any symptoms, and he got COVID free. Then another case where a patient's husband comes in with COVID, and the patient also gets COVID, but completely got over it. So what I wanted to impress on the patient is that I don't want them all to be fearful that they are sitting duck and this COVID is going to come and get them. And that's why for the rest of the time, they are completely afraid to move or do anything. I don't want them to be in that state of mind, number one, because even when the surge was there in New York, we did not see that they were the people who ended up being. Comorbidities, yes, myeloma is a comorbidity, cancer is a comorbidity, treatment for cancer is one of the comorbidity, lung, hypertension, diabetes, and all those things. But when we look at the number of patients who ended up getting admitted in Mount Sinai, the number of patients who did not have cancer was far more, and the number of patients with cancer was lower. And in that population, the number of patients with myeloma were a handful. So I just wanted to say that because this is a patient seminar, so I don't want them patient to be petrified. But I'm not quibbling with the fact that the myeloma patients are in general considered immunocompromised. But I have patients who have got COVID and they fully recovered. And we talked about slight delay in the shedding of the virus and the making of antibody. Those are information we are trying to ascertain at this time.
Okay. I said we we're going to ask one more question. I'm going to actually ask two more. And so we may go a little bit over, but we will have to stop at one point. I'm asking this, and I'm going to read the entire question because there's a lot of stuff in here that people hear on the news, and we'd just like for you to discuss that. And I'm going to just read the entire question. It's rather lengthy. I have smoldering myeloma and also sclerodoma. I have been taking hydrochloroquine for over a year. I have severe upper respiratory bronchitis, and I had severe bronchitis in December, lasting for 6 weeks with 2 rounds of Z-Pak and penicillin and steroids. Many people have had incidences of what might be the coronavirus in December. Do you have any patients that you consider might have had the virus as early as December? And do you agree the protocol of hydrochloroquine, Z-Pak, and zinc as a protocol to deal with the coronavirus is good for myeloma patients?
So we don't know because there's a limitation on the amount of testing. And so at Mayo, with the number of kits we have available, we're not permitted to test patients who are completely asymptomatic or had upper respiratory symptoms 4 months ago. We require patients to either have shortness of breath, fever, or direct exposure to a known corona. So I don't actually know how many immune previously infected patients there are out there. Already the randomized trial with hydroxychloroquine has been abandoned due to toxicity. And taking hydroxychloroquine outside of a clinical trial is dangerous. They stopped the trial because there's this syndrome called long QT interval, which causes problems with the repolarization of the electrical signal of the heart, which can lead to serious life-threatening rhythm disturbances. So the idea of taking hydroxychloroquine in an outpatient, unmonitored situation, I just think is dangerous. And so the cocktail, and zinc isn't exactly benign either, because I've had people permanently lose their sense of smell from the use of zinc. And so if you're in a trial where there's a safety plan and active monitoring in place, okay. But asking your doctor for a prescription for these medicines, I think that that's completely wrong.
Okay.
I would agree with that. The patient indicated they might have been on hydroxychloroquine for another rheumatologic condition, and I think that's appropriate if they're being monitored. But I would really caution against self-medicating to try in an idea that you're going to prevent this infection outside of a clinical trial. The question also indicated that there were respiratory symptoms back in December. I don't believe that we know of any known cases outside of China that far back, so I think it's highly unlikely. But only time will tell. You know, perhaps we can have serologic testing to tell us about prior infections. But I think it's highly unlikely that it was anything other than a respiratory other virus or cause of a respiratory infection.
Okay. And the last question and little editorial, started with Dr. Jagannath today, and I'd like to end with Dr. Jagannath, and feel free to add if you want. You know, one of the greatest curses you can get is may you live in interesting times, and we all know what that curse means right now. We'd like a little bit of boredom and routine for a change. It struck me, Dr. Jagannath, that on September 11th, 2001, you were working in St. Vincent's Hospital, which is the hospital closest to Ground Zero and which received the first patients and the first medical care that people got during September 11th. Now you're at Mount Sinai, which is arguably the center of the coronavirus issue in the New York metropolitan region. Can you just give us some personal insights about this, just personally and professionally, about catastrophes like this and how to get through them?
Well, both of them impacted on me directly. In the first case, 9/11, you know, it was shocking. I used to live in Battery Park City, which is right next to the Twin Towers, as they were called at that time. So right away, there was no way of going back home, period. That whole area was cordoned off by National Guard in the southern tip of Manhattan. Below Canal Street was cordoned off by guard. And then I had to go pick up my son from his school because all the transportation, etc., came to a halt. And my wife was in New Jersey. She was working at the time for Blue Cross Blue Shield and as a computer programmer. And she had to stay back in New Jersey that day. So even the family, we could not get together. Then from next day onwards, we had to find a hotel to live and go shopping for khakis and Gap. So that's when I became a fan of wearing khakis and white shirt as a routine. And so you could see right from toothbrush we had to buy because for 2 months we couldn't get back into our apartment complex at all. So it had a major impact. On the medical side, it was interesting. We had a lot of patients coming from the dust for a lot of eye washing and things like that. But when the Twin Tower collapsed, the people who were in the building, they just all perished. So there was very little saving of lives in reality. Everything was set, from our cancer center. They whisked away all the beds and oxygen tank and things like that. We were rescued. It was all kept ready at the St. Vincent emergency room, even on the street. Gurneys were kept and ready. But nobody came. That's a tragedy of an immense proportion of a different type, which affected me differently. And of course, then slowly easing up. And of course, they said there was no air pollution. You can breathe. Governor of New Jersey, a woman said that there is no toxic fumes, nothing like that. So that was all wrong because now I'm taking care of a lot of World Trade Center firemen and policemen with multiple myeloma. And we reminisce on that. And so that was really sad. But you could see how the leaders cover up and tell things what is expedient at that time. Now we are in a completely different scenario. Now we are threatened by a virus, which, as I said, it trickled in on March 12th. We had something like 20 patients. By March 24th, we had 500 patients. By March 31, we had 1,500 patients. And then by April 6th, we had 2,000 patients. That absolutely subsumed your entire institution and all the personnel trying to provide care for them. And even the myeloma doctors, my younger colleagues, they said, you are older and you are vulnerable. I should thank them for it. But they all volunteered to go into the COVID medical services. And they are actually doing rounds on these patients because the fellows in hematology, oncology, they were all completely rerouted to man the COVID services and take care of these patients. But at the same time, I could see how the entire institution, because it's a medical school, rallied around the science part of it, which was all channeled towards doing clinical trials immediately for coronavirus patients and testing them, providing our own institutional test with the turnaround time of 6 hours. And hopefully the turnaround time will be 2 hours when the patient come to the clinic, getting the serology up and running so that they can do the clinical trial with the convalescent plasma and allowing us to bring in clinical trials, randomized phase 3 clinical trial during this time so that we can find out which one works, which one doesn't work as it unfolds in the rest of the country. So it has been done with enormous personal cost. I know my colleague who was an intensivist, she herself got COVID. I told you about my nurse in the clinic whose both parents died of COVID, leaves you feeling bad because she had COVID, whether she brought it home or what happened, but both of her parents died. It leaves so much to be said, so there were people who got COVID. And you might have known this news report of a young nurse who was a nurse manager who got COVID, and he was in the ICU texting his sister, do not tell the parents I'm in the ICU on oxygen, but I'll be okay, I'll come back. And he passed away, So you could imagine, and this was a Mount Sinai employee. So you could see that this is not statistics for us. It really is us as people, colleagues, friends, family, things like that. So it is an immense impact. But at the same time, we are now hurling towards what is the post-COVID era, how to reopen the institution, which had completely shut down their operations, elective surgery, elective radiological imaging, elective, and also changing how we manage patients in the clinic with the cancer patient, ongoing treatment, etc. Now we have to come back to the normalcy. So we'll be busy over the next 2 months how to get back to normalcy how it is. And in New York, we all use public transportation. I go by subway every day to work. And that is something now we are all looking about, everybody wearing a mask. Yes, I wear a mask, not so much that, I'll be protected by the virus coming in through my cloth mask or whatever mask I have, homemade mask, but at least I do not have my, secretions or cough or, cough droplets get out of me so that I'm protecting others. And if everybody does that, that makes a big difference in the safety as the future goes on. So I'm pretty sure that there will be a lot of changes how we do. And you heard Dr. Gertz telling how even medicine will be practiced, how the crowding in the waiting area, etc., will be for sure changed. So there is going to be a lot of change. But this has had an enormous personal impact, especially when I have elderly parents, 91 and 90-year-old, and one of them, my father, has pulmonary fibrosis. He has enough comorbidity, and he would not want to go to the hospital to be completely isolated from a family and to be admitted in the hospital and asked to be on a ventilator. So you have to literally at home, you will make a decision. You're not going anywhere, So it is a really a traumatic and personal experience that we had to go through and I had to go through.